Okay, I think I need to get on with this presentation. Just to, you know, revive you a little bit, how many of you deals with hypothyroid management or thyroiditis? Can you just, with a, okay, so these people, about 5, 6, 7, 8. Again, how many of us deal with Hashimoto's thyroiditis? Do you feel it's quite common? Yes? No? Are you seeing more cases with autoimmune thyroiditis? Yes. Yes. How many of you deal with or see cases with thyroid cancer? 1, 2, 3, 4, 5, 6. Okay, good. And the ladies at the back, are you family physicians or endocrinologists, diabetes, residents? Ladies, talking to you? Family physicians, GPs? Okay, fine. So I just wanted to highlight a bit of a refresher about Hashimoto's thyroiditis and the link between this condition and thyroid cancer. So what I'm going to do is just to scratch your head about what things that you can just follow regularly without any digging into what can be cancerous and what not cancerous, and what can be just taken for granted as just a simple, pure Hashimoto's thyroiditis with or without supplementation of thyroxine. So we look into the epidemiology of Hashimoto's with thyroid cancer, a bit of pathophysiology, some cytopathological challenges, and prognostic reflections. As you all know, the word Hashimoto's thyroiditis is basically refers to the autoimmune process of inflammation, chronic inflammation of the thyroid gland, or chronic lymphocytic thyroiditis, and that is more descriptive. It is basically characterized by either enlarged thyroid gland, or we can see an atrophic gland where the size is actually much smaller. But in all cases, there should be, in order to have a Hashimoto's thyroiditis, and lymphocytic infiltration and elevated serum autoimmune antibody levels. And if you perform a neck ultrasonography of the thyroid itself, and these are, most of them are cross-sectional pictures, and you can see that it can, in all of them, there is a marked heterogeneity of the parenchyma. That some of them could be hyperechoic, some would be hypoechoic, there would be some scarring, some spickled changes, or Swiss cheese, or pseudocystic, or pseudonodular. So you would see a variety of parenchyma that can reflect with your ultrasound description. And that actually potentiate your diagnosis to detect autoimmune thyroiditis or Hashimoto's thyroiditis with or without nodular thyroid. So how large is that condition? Well, what is the prevalence of Hashimoto's thyroiditis? So I'm just quoting one of the largest surveys that has been done. It's actually a systemic review. It's not a survey, just a systemic review with a meta-analysis that looked into the global prevalence and the epidemiological trends of Hashimoto's across multiple continents. And they found that the prevalence of Hashimoto's thyroiditis in women is 17.5%, whereas in men is about 6%. And the risk of a woman to develop Hashimoto's would be 4 times that of an adult man. The highest prevalence was quoted in African adults, about 14%, and the least was in Asian people, about 5.8%. I'm not aware if we have done any prevalence studies in the Middle East or in the Gulf region to detect how prevalent we're seeing Hashimoto's thyroiditis, but I'm sure that you would agree with me that we're seeing more and more of those cases. Now, if I want to flip the page and look into the incidence or the spread of the thyroid cancer, on the other hand, You can see that this is, again, one of the latest publications that looked into the global incidence and the mortality rate of thyroid cancer from the GloboCan data 2020. And you can see that in women, there is an age-standardized rate of the incidence rate of thyroid cancer about 10 per 100,000, compared to 3 adjusted age-standardized rate per 100,000 men, while mortality more or less remains very much under control. If you look into the right-hand side of this table, you can see that the mortality rate, whether in men or women, is quite low. Moving forward to the global incidence and what are the countries or people who are affected by the thyroid cancer, and you can see that on the top part, the French Polynesian, or in the USA and Canada, they have a higher incidence rate of thyroid cancer compared with Central Africa, where the detection rate is actually low, and therefore the incidence rate is also low. I just wanted to highlight what happens in South Korea. And of course, maybe for those of you who deal with thyroid cancer and the review of their literature, we know that they have, as part of their national health system, they have screened people for thyroid cancer or nodularity with an ultrasound, and they've actually detected much higher numbers of people with thyroid cancer. I just wanted also to highlight that in the Arab area, especially in the Gulf, we are considered in the West Asia. We have the highest detection of incidence rate of thyroid cancer detected in Turkey, while the least would be in Yemen. And I think it's a detection issue and accessibility to NIC ultrasound. While when we talk about the global mortality rate, things are much less. But again, we can see that interestingly, we can see that, for example, in the West Asia, United Arab Emirates have scored highest in terms of mortality rates for that particular area, geographic area, and Bahrain scored the least. Congratulations, Dr. Wiam. You're doing a good job. All right, so I feel that both conditions are we're seeing more of them. Obviously, Hashimoto's thyroiditis, we're seeing more compared to thyroid cancer, but both can coexist. And the data supports that we're having a big scope of the prevalence of parathyroid, of thyroid cancer, especially papillary thyroid cancer in patients with thyroiditis. And it all depends on the population studied. And it ranges between 4.5% to 58%, depending on the publication type and the quality of the data collected. So in order to link thyroiditis, chronic thyroiditis, as a risk factor for thyroid cancer, we need to have a proper design for those studies. In terms of this has been already established. So in case control studies, they've looked into the odds ratio, and there has been a significant increase in the risk of developing thyroid cancer in patients with Hashimoto's thyroiditis. And also in cohort studies, there has been a higher rate of detecting thyroid cancer prospectively if we follow patients with Hashimoto's thyroiditis. So I think there has been plenty of published work linking Hashimoto's thyroiditis as a risk factor for thyroid cancer, regardless of the TSH level. So if I wanted to look into some of the imaging, we have this lady that came to my office like 2 weeks ago, and she has this, obviously you can see that there is a heterogeneous gland, and she has this right-sided irregular border hypoechoic nodule, probably some calcifications in it, and I did not like that nodule. And maybe you can say that it has a bit of a taller rather than wider in terms of dimension. That came up to be category 5 with Bethesda categorization. Another, I had a young man who had also autoimmune thyroiditis, but he has that small, about 1.3, probably mixed nodule that I wasn't really keen to biopsy, and I kept following him up. But then with the follow-up, I realized that he's having more of the lymph nodes that are swollen, and they looked really suspicious. So when I biopsied that immediately became, I biopsied first time and it was category 3, and then the second time it was category 6. This is one of the patients also that we commonly see. This is a left-sided nodule, which is heterogeneous. It's isoechoic and not really hypoechoic. In terms of an ATA risk categorizations, probably you would say that this is actually a low risk and you wouldn't really biopsy. Anyway, the patient, as we see, as you know, that patients panic as soon as they know that they have a nodule, and then you end up biopsy anyway. And that came out to be category 3. So with category 3, then you can go into, you explain what are the guidelines with the category 3, and you need to repeat, or you need to remove the lobe, or you need to replace, and there's a big chapter of discussion that you need to do with the patient. So what would be the mechanistic explanation for the association between Hashimoto's thyroiditis and the papillary thyroid cancer in particular? So one would be the elevated level of TSH, and we know that TSH has been proven to be an independent risk factor for thyroid cancer, especially the papillary carcinoma. Another is the sustained inflammatory process that has been also proven across so many publications that it can trigger cancerous changes. The Hashimoto's thyroiditis can exhibit some cytological alterations, some nuclear modifications that are similar to what has been seen by thyroid cancer. So there's really poses a diagnostic challenge when you actually do some aspiration with the FNA. And then there is this solid cell nests that are often small. They consist of polygonal to ovoid cells that have finely granulomatous chromatin and show nuclear grooves which simulate and can actually be present in both Hashimoto's thyroiditis as well as the thyroid cancer. So there is a common mechanistic explanation that can link both Hashimoto's thyroiditis with papillary thyroid cancer. So what is the impact of this association? Why am I presenting this association between those two? One is because there's a bit of similarities, and that poses diagnostic challenge. Two is because of the prognostic measures that we might take and what puts a patient into a higher risk or a lower risk. And also, we can think about some management issues. If we have a patient with a thyroid nodule and has chronic thyroiditis, changes as well with autoimmune thyroiditis. In terms of a cytology or the FNA, we know that the influence of Hashimoto's on thyroid cytology, particularly using the Bethesda system, can actually be either misleading or confusing. And we've actually, if you look into the column where there is a Hashimoto's thyroiditis, you can see that we are seeing more patients with the indeterminate or level 3 or level 4 cytology, and also positive for malignancy, more than those who are having a thyroid non-Hashimoto's thyroiditis. And the figures that has been quoted is that the indeterminate Bethesda 3 and 4 is almost 26% compared to 21%, a significant difference between the two. What about cytopathology? If you open up and remove the thyroid, we can see that patients with papillary thyroid cancer in a background of Hashimoto's thyroiditis, they're having more multifocality, they're having less extrathyroidal involvement, less samoma bodies, and the BRAF mutation is also less. So I feel that there is those patients with Hashimoto's thyroiditis, even if they develop thyroid cancer, they might behave differently. And therefore, our management should be tailored to those patients a bit differently as we collect more and more evidence. So do patients with pre-existing Hashimoto's thyroiditis who develop papillary thyroid cancer, do they do better or they do worse? And in terms of prognosis, we look into recurrence rate, mortality rate, and other disease-specific complications. And this is brought from a recent retrospective cohort study involving more than 9,000 patients between the ages of 18 to 75 from a single center in China. And they have actually found, and these are Kaplan-Meier graphs, and looking into, there has been a significant reduction in the risk of recurrence in patients with Hashimoto's thyroiditis. In other words, the recurrence-free survival is better in patients with Hashimoto's thyroiditis, and this has been observed in the unadjusted data as well as in the adjusted for sex and age. What about mortality rate? So mortality rate, we know that thyroid cancer in general, they do well, but those subcategory with Hashimoto's thyroiditis and papillary thyroid cancer, they actually do even better. So we have the disease-specific survival is much better, whether it has been unadjusted or adjusted for the sex and age of patients with Hashimoto's. What about papillary thyroid cancer specific outcomes in patients with Hashimoto? So this is a quite recent publication. They looked at 47,000 patients from 65 studies, variable study design, and we have like 20,000 people with Hashimoto's and 34,000 without Hashimoto's, and we can say that the lymph node metastasis was much less detected in people with Hashimoto's thyroiditis, whether central node metastasis, lateral node metastasis, or overall metastasis. If we want to look again into distant metastasis or vascular invasion, we also find that we have patients with Hashimoto's thyroiditis, when they develop papillary thyroid cancer, they have a lower incidence of extrathyroidal extension, distant metastasis, lymph node metastasis, vascular invasion, and general better prognosis than patients without Hashimoto's thyroiditis. So should we, after having this information, now we know that if we believe that patients with Hashimoto's thyroiditis, they are at a high risk of developing thyroid cancer, but should we screen patients with Hashimoto's thyroiditis for thyroid cancer or not? So this question was answered by the US Preventive Service Task Force, and it was recommended against screening patients because there is actually no impact on mortality rate, and it's not really cost effective. You will detect and overdiagnose patients with thyroid cancer without real impact on their mortality rate. So this has been clearly emphasized in the literature. But at the same time, this is the last slide, I just wanted to have your views and opinion about this case, which is a quite common case. So this patient, a 35-year-old lady with Hashimoto's thyroiditis, elevated antibodies, T3, T4 are normal, and the TSH is around 2. And she has this nodule on the left side. It's about 2 centimeters. The question is, would you perform ultrasound-guided FNA? We are. Yes? Dr. Tamer. Okay, so yes, we will do an ultrasound. Why? Is it because she's Hashimoto's or because of the actual look of the nodule? Yes, so whether the patient is having autoimmune thyroiditis or not, we just evaluate the nodule as it is and looking into the risk signs of having a cancer or not. So, number 2, would you perform molecular markers or tests for this patient, if it is available? No? Kosti? Dr. Muhammad? Yeah? Yeah? Dr. Tamer? First, we'll do FNA. That's a smart answer. So we will keep, as per the guidelines are saying, that we will only do molecular markers if it is category 3 or 4. So again, if it is benign, then that's fine. But if it is in the gray zone, then you might need to ask for molecular markers. X-ray where? Of what? Yeah, but X-ray of what? Of the chest, of the neck? We don't do X-ray, plain X-rays. Yeah, you mean ultrasound, yes. So of course, so this is an ultrasound of the thyroid, and that is the nodule, and the right side does not have any nodules, it just have heterogeneous gland. The left side having this looks well-defined nodule. It is hypoechoic, but it's taller than wider, and it justifies all the necessary risks that would actually push us to do ultrasound-guided FNA. But then after that, doctor, we would really need to see whether it is a benign, intermediate, or malignant. If malignant, that's it, fine, we have an answer. But if it is in the intermediate, would we go one step further if the molecular markers are available? Maybe yes. So because knowing at the back of our hands, of our head, that this is an autoimmune thyroiditis, she has a high risk of developing cancer, and I have an indeterminate pathology with a more 27% risk of malignancy, then compared to people who are not having autoimmune thyroiditis, then I would be actually asking for molecular tests if it is available. Now, the major question here, we know that molecular biology is not available. Would you suppress her TSH? Would you give her thyroxine? No. Victoria, no. So I think we will hear more and more about suppression of the TSH in people with suspected thyroid cancer and a borderline high TSH. So far, the guideline states against giving a thyroxine. But keep in mind, and maybe in the future studies, we will need to address that question more in depth, because knowing that they're having more risk of developing thyroid cancer might actually let us put the patient on a small dose of thyroxine to suppress the TSH. Because now TSH is an independent risk factor for thyroid cancer, autoimmune thyroiditis is another risk factor for thyroid cancer. So this is just to tease your brain about not to take autoimmune thyroiditis lightly. So there is more to discuss about these cases. Take-home messages, the prevalence of Hashimoto's thyroiditis is about 7.5. We're seeing more and more of these cases. We don't have local data. The incidence of thyroid cancer is still under control, where again, the more you detect, the more you do ultrasound, the more you will detect. Both Hashimoto's and thyroid cancer can coexist together, and the evidence suggests that Hashimoto's is a risk factor for thyroid cancer. And then in spite of the diagnostic challenges in terms of cytology or the histopathology, sometimes it's difficult to discriminate confidently between the nodules with Hashimoto's versus thyroid cancer. However, the prognosis remains excellent and with less metastasis and better recurrence rate. And the issue of thyroid nodules, if we have a nodules in a patient with thyroid autoimmunity, really deserves an in-depth follow-up by imaging, molecular markers, and possibly TSH suppression in future studies. Thank you very much.